Good evening, everyone. Myself, Dr. Sakshi Pathak. I'm a junior resident, currently working in the Geriatric Medicine Department at IMS PHU. Today, I welcome you all to Respiratory Conclave Conference 2026. Due to some shortage of time, we'll have to shortly begin the session. So for session 1, the topic is Recent Advancement in the Management of Sleep Apnea by Dr. J.C. Suri, sir. For the first session, I would like to invite the chairpersons of the session. May I please request Dr. Amit Johri, sir, to join the stage. Dr. Mohit Bhatia, sir, to join the stage, please. Dr. K.K. Tripathi, sir, please join the stage. Dr. K.K. Tripathi, sir, please join the stage. Dr. Abhishek Pandey, sir, please join the stage with us. Now I would request the chairpersons to kindly invite Dr. J.C. Suri, sir, for conduction of session 1 on recent advancement in the management of sleep apnea.
Good evening, everybody. I hereby welcome Dr. J.C. Suri. Dr. Professor J.C. Suri is a highly renowned pulmonologist based in Delhi, widely considered a pioneer and the father of sleep medicine and critical care in India. He is credited with establishing the country's first clinical sleep laboratory at Safdarjung Hospital in 1990. He is chairman of the JCS Institute and ex-HOD Department of Pulmonary Critical Care and Sleep Medicine, Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. Dr. J.C. Suri, sir, we have always known you as the person who has trained generations of people for NIV and sleeps. So everybody is quite eager to listen to you. Over to you, sir.
Good evening, everyone. At the outset, I would like to thank Dr. Pathak for this invitation, and also thank you, Chairperson, for the nice introduction. I am quite privileged to be speaking in front of a distinguished gathering of my senior teacher like Dr. Rajendra Prasad and my distinguished colleagues which have come from all over the country. I will be talking about a subject which is very exciting and which is evolving over the last few years, and it is the most important aspect of sleep medicine, that is the management of obstructive sleep apnea. We all know that for the last few decades, in fact ever since the treatment for obstructive sleep apnea has started, we have considered CPAP as the single and the most important treatment, what you call that one size fit all. That's what we have been doing. But now we know very well that there is a change in the paradigm. And this change in the paradigm is that from CPAP only to precision guided multimodal care. So that's the new paradigm which we have to understand. And what I am going to do here is to enumerate various factors and other treatments which will improve the management of obstructive sleep apnea. And not only I am going to enumerate treatments other than CPAP, and we will see that how it is changing the outcome of the disease over the last few years, So before we go into the other management, it is very important to know what actually obstructive sleep apnea is. Sleep apnea is basically not a simple sleep disorder. It is a multi-system disease with far-reaching health consequences, and the most important one are the cardiovascular diseases like hypertension, heart failure, stroke, atrial fibrillation, metabolic disorders like insulin resistance and type 2 diabetes, and another important is the neurocognitive problem like excessive daytime sleepiness, impaired cognition, and reduced quality of life. It's a very highly prevalent condition, as you know that 1 billion individuals worldwide are suffering from obstructive sleep apnea. So if you have a patient of, say, resistant hypertension, or a patient with difficult to control diabetes, or patient with intractable sleepiness, then always think in terms of obstructive sleep apnea as one of the contributing factor for this. And so far, CPAP has been considered to be the gold standard treatment. But as you can see, the major problem with CPAP is the poor adherence. CPAP is a very efficacious treatment. If you treat a patient in the sleep lab, you will see that with CPAP you are able to control 100% of the problem. You can completely resolve all types of sleep apneas, but the problem is its long-term effectiveness. So the major problem, if you can see here, is that of adherence. Only 45% of the patients whom you start with CPAP will be adherent, and about 40% will never be, you can say, practically non-adherent. And if you look into short-term adherence of 3 months, only 44% of the patients are complying with this problem. So even if you have a kind of treatment which is the best in the world, but if you give it to the patient and patient doesn't accept, then it is considered to be worthless. So we must know 2-3 things. One, why the patients are not complying with CPAP, and number 2, we probably has made sleep apnea as a very simplistic disorder. So traditionally, if you see that once we make a diagnosis of OSA, we prescribe CPAP to all patients, and this is only one single intervention which is prescribed to the patient, and it's mainly AHI centric and reactive management. Now what basically we want is a change. There is a paradigm change, is the precision model. So when we say precision model, that means the treatment is matched to the patient's phenotype, because sleep apnea is a heterogeneous disease, and it has various clinical phenotypes and physiological endotypes. So these patients are a group of heterogeneous disorder, and giving one single treatment to all of them is not likely to be successful. So the major shift which has taken place in the last 1 decade is the change from traditional model of one-size-fits-all treatment to a precision medicine, where you are giving these patients a multimodal combinable therapies, and they are endotype driven and basically proactive. Now, to understand the newer treatment, first of all, we must know what is the factors contributing to upper airway obstruction in a patient of obstructive sleep apnea. And you can see that there are multiple factors which can contribute to upper airway obstruction. Most important are the craniofacial factors, the anatomy, where we all know that most of the sleep apnea patient has an anatomically small pharynx, and for that both bony craniofacial structure and soft tissue factors like enlarged tongue, enlarged tonsils, and short facial bones like micrognathia, agnathia. So these are the important factors. And then altered muscle function is another one. The high loop gain and low arousal threshold. So if you see that this obstructive sleep apnea is basically very complex pathophysiologically, and anatomical factors like small pharynx is just one of them, and the other factors are like low arousal threshold, high loop gain, altered muscle function, fluid shift, and obesity. So all of them are contributing to this. And recently what we have learned is that there are 4 types of phenotypes which we can see in patients of obstructive sleep apnea. Number 1 is the high airway collapsibility. What we mean is that most of these patients will have an anatomically small pharynx. That is the most important thing. 100% of sleep apnea patients will have anatomically small pharynx, and then along with this they will have other factors which will contribute to upper airway collapse, and these are low arousal threshold, high loop gain, and poor muscle responsiveness. So it becomes very important for us to understand our patient and see which of these endotypes are contributing to this, and that is the reason that we need to have a precision therapy, because different patients will have different permutation and combination of these endotypes, so the treatment is also likely to be changing based on these factors. So beyond the devices, we also have newer treatments like mandibular advancement devices, positional therapies, myofunctional therapy. Surgical treatment has also evolved very significantly over the last 1 decade. And in this, the most important thing which has come is hypoglossal nerve stimulation, maxillomandibular advancement, and then some improvement in the palatal surgery. And then some drug therapy is also on the horizon, and there are few drugs now which are being in their phase 3 trial and are likely to come very soon, maybe within a year. They may get FDA approval, and this will be I think the major breakthrough in the management of obstructive sleep apnea. So if you could see that we have now multiple therapies besides the device. As you can see here, CPAP and APAP, that's the only treatment which is being prescribed to most of the people. But if we evaluate our patient properly and type their additional factors like phenotypes and endotypes, then we can consider additional treatments. So though the era is of combination therapies rather than the individual therapy. So one thing here I would like to mention that the next treatment, the treatment which is most established non-CPAP treatment is the mandibular advancement devices, and they have now come up very well over the last few years. We now have a longitudinal data regarding their efficacy and also their effectivity for this thing. So if you just to look into the role of the dental devices, previously we have been using them only for mild to moderate OSA, and the patients which are most suitable for this are the thin people who are non-obese, younger people, and having a mild to moderate OSA, particularly those patients who are not tolerant to CPAP or who would not accept CPAP. So that is the major group here you can see, and if you compare mandibular advancement device with CPAP, you will see that if you look into the different domains like their efficacy as far as their AHI reduction is considered, then of course CPAP is better than mandibular advancement device. But if you look into sleepiness, quality of life, and this thing, it looks similar. But looking into the adherence, you will see that adherence has found to be much better with mandibular advancement devices than with the CPAP. And on the other hand, if you take into account the patient's preference also, this is considered to be much higher. So that way, if you see, if you compare CPAP versus mandibular devices head to head, though CPAP may be better in decreasing the AHI, but the compliance probably is much better. So overall, long-term effectivity of the treatment may be better, because if you use it for longer period and more number of hours each night, then probably the mandibular advancement devices may be as good or even maybe better than CPAP in selective patients. So that's very, very important here. If you can see the overall success and adherence, and if particularly use more than 6 hours, I think this is a very good data, and it is much better than what we know about the CPAP devices for this thing. So, and then another problem is that initially a treatment may be effective, but what about its long-term role? Whether the patient is complying with that problem on long-term basis. So what we have now seen that there is a sustained benefit, and the efficacy and effectivity of mandibular devices is much better and is equivalent to CPAP when we are comparing different parameters. So you can see that there is a sustained AHI reduction continues to be there at 3 years. And if you compare with the similar the compliance with CPAP, it is relatively much smaller for this thing. So how to optimize mandibular advancement therapy? Here the important thing is the patient selection. That's number one, very important. And previously we have been giving them custom devices, what we used to call boil and bite. So you just have a custom made they are already, those devices are available. You put it into a boiling water and put it in the mouth, boil and bite like this. But now we know that custom made devices are much better in terms of compliance and also with in terms of efficacy. So you can see that if you have selected your patient properly, 72.1% overall success rate has been seen. The good thing now with the modern mandibular advancement devices is that, like CPAP, you can also titrate the degree of mandibular advancement which you want to have with this. And the most important part, which one investigation which has played in improving their efficacy and effectivity is the drug-induced sleep endoscopy. So drug-induced sleep endoscopy is one modality which has significantly helped us in selecting our patient both for orodental, this MAD devices, as well as for the surgical treatment for this thing. These are the newer treatments which are coming, where both the positional and the myofunctional therapies. They have also been found to be useful, though they are not as a single, as an individual treatment has been found to be good, but positional therapy as an adjunct treatment to other known therapy has been found to be useful. So one very important place where positional therapy has been found is following bariatric surgery. So following bariatric surgery, if there is a significant weight loss, maybe 25 to 30 kg, most of these patients who were severely sleep apneic, they have become positional sleep apneic. So they would have in one particular position. So if you give them positional therapy, they are practically cured of this disease. And now we have different types of, vibratory devices are there. Then which can, or wearable devices are there, which can help us in maintaining a particular position during this. What about the soft tissue surgeries? The soft tissue surgeries are also now coming up. You must have heard about UPP, uvulopalatopharyngoplasty. This surgery is useful for selective patients who have only problem in their soft palate and in the nasopharynx. So if you remove their decrease the size of their palate and remove the lateral pharyngeal soft tissue along with adenoids and tonsils if they are there. So this surgery can be helpful in select group of patients, and those patients again we can only select with the help of drug-induced sleep endoscopy. This is the surgery which has, I think, not been used very much, at least in India, because we have very few maxillofacial and dental surgeon who perform this kind of a surgery. But this is the most effective surgery. Here, what you do is you advance both maxilla as well as mandible, and you actually make pharynx, which is basically nasopharynx, oropharynx, and hypopharynx. So by advancing the maxilla and mandible, then I think you may be able to treat and in fact cure majority of patients of sleep apnea. As you can see here, the success rate is about 90%, and complete cure can be seen 45 to 5. So what is the difference between complete cure and success rate? Complete cure is when the apnea-hypopnea index you can achieve if it is less than 5. But surgical success means when we are able to reduce the apnea load to at least 50%. So that's what is important here is that now the newer things which have come are the 3D imaging with virtual surgery. So now what we can do is you can create a 3D imaging, and on the computer you can do the surgery and see the results. And with that help, I think what is we called as now personalized MMA, and with that you can see that the success rate here. You see the mean AHI, which has been reduced from 42.8, which is a severe disease, to 6.3, which is almost like a normal thing. So this is the data which we are seeing, and with the newer techniques of diagnosis, selection, and minimal surgery, I think this surgery, particularly for those patients who are not tolerant to CPAP or who are not accepting CPAP, will play a major role in future, this thing. Then weight reduction. I think obesity is one of the major risk factor for obstructive sleep apnea, and it has been seen that if you reduce the body weight by 10%, it will result in 50% reduction in apnea-hypopnea index. So we have 3 types of methods by which we can achieve a significant weight loss. One, the lifestyle modification. With the lifestyle modification like diet and exercise, you may be able to achieve about 5 to 8% of weight loss, maybe maximum is 8 to 10 kgs. But with the help of the modern drugs, the new drugs which are the GLP-1 agonist, now we can achieve significant weight reduction. So the new drug like tirzepatide, with that you may be able to get a weight loss of 15 to 20 kgs. So that's a very significant thing, more than 10%. Of course, if you want long-term and sustained weight loss, then you can have bariatric surgery. So these are the 3 things, which again are grossly underutilized in the treatment of obstructive sleep apnea. So though when you achieve this weight loss, you may not be able to cure sleep apnea in majority of cases, but there will be a significant reduction in the severity of the disease for this thing. The new treatment which is becoming very popular is the hypoglossal nerve stimulation. So this is a treatment which addresses the neuromuscular function. We know that obstructive sleep apnea is a disease which happens in sleep. And most of sleep apnea patients are able to maintain their upper airway and can breathe normally during wake time. So it's only during sleep, when their wakefulness drive is gone, there is a sudden withdrawal of this drive, and the pharyngeal dilator muscles, particularly the genioglossus muscle, tonicity is reduced, and it results into upper airway collapse. So this, the tonic and phasic supply to the genioglossus muscle, which is the major pharyngeal dilator muscle, comes through the hypoglossal nerve. So hypoglossal nerve stimulation is now coming up as a very important treatment, and though it is not yet very popular in India, but outside India this treatment is actually becoming very popular. And there was a trial by what we call STAR trial that has shown very good results. This thing, and the patients which have been covered in this trial were moderate to severe disease who are unable to tolerate CPAP. And the important thing here is that they should not be very obese. Their BMI should be less than 32, and there should be no complete concentric collapse. Now, this is a kind of a finding which we get through drug-induced sleep endoscopy. So what is important here is that if you are not doing drug-induced sleep endoscopy, then probably you will not be able to manage these patients effectively. So, this with proper selection, then I think this treatment will become a very popular treatment in future. The only probably impediment is that you have to do a surgical implantation. So you have to put an implant to stimulate hypopharyngeal nerves. But what is happening now in the newer one, we are this treatment is evolving. Now we have a newer method of both side stimulation, and now we have non-invasive. You can put a patch on the neck and you can stimulate the hypoglossal nerve during sleep. The problem is the amount of stimulus which you have to give to this nerve to maintain the upper airway. So that's, I think, a major problem. But I would say that this treatment is still evolving, not only in terms of the devices, but also in terms of indication. Now, the original patients which were taken in the STAR trial, now we are actually extended those indications, and more patients are coming under this thing. So there is an expanding, this expanding beyond the traditional candidates for this thing, you know. And finally, I would like to talk about the pharmacotherapy. And in the pharmacotherapy is basically, again, to address the neuromuscular function of the upper airway. And there are 3-4 categories of the drugs which are being developed in pharmacotherapy. One is which will do the same function as we do with hypoglossal nerve stimulation. So these drugs are basically a combination of the drug which is in phase 3 trial, and the results are very encouraging. So if it gets an FDA approval by next year, then probably this will be the biggest game changer. So here you can see this atomoxetine, this combination here. Yeah. So this drug, though name is AD109, it's basically a combination of eroxybutynin and atomoxetine. So these are the two drugs, you know, and the other drugs which we are developing is to address the endotypes. So, and like if the patient has high loop gain, then we are developing carbonic this acetazolamide group of drugs we are developing, and also for patient with low arousal threshold, the sedative drugs are being used. So these are, I think, the important drug, and this drug is being definitely showing a lot of promising result. And the another one, the Sultiam, which is the carbonic anhydrase inhibitor drugs, which will be basically used to improve ventilatory response, particularly those patients who have a combination of upper airway obstruction and high loop gain. So what we call the complex sleep apnea. So just last slide here. So the 5 take-home message which I would like to give here is that CPAP remains the foundational. This is still the gold standard treatment. And those patients who are not able to tolerate CPAP, MADs are the most mature non-CPAP treatment. And the other treatment which are becoming very popular is, one is the hypoglossal nerve stimulation. We already have more than 5-year data on this. And the 2 upcoming treatments are the pharmacotherapy. And in the pharmacotherapy, you have drugs to treat sleep apnea per se, and also to treat the endotypes, And ultimately now, in the future, what we are going to have is the precision therapy, where you will use combination of treatment. So that the era of a single treatment with CPAP is almost gone. And in future, if you want to treat this patient effectively and also improve their compliance, you will have to use some kind of combination where you will use CPAP with oxygen, MAD with positional therapy. So like that maybe you may use CPAP with oxygen, with sedatives, with even drugs like carbonic anhydrase. So that's the way you are going to treat from simple sleep apnea to complex sleep apnea. Thank you very much for your kind attention.
Thank you, sir.
Thank you so much, sir.
Thank you for the excellent deliberation. Thank you for making us abreast with the latest in the management of sleep apnea. Now, with the constraint of time, I would permit only 2 questions from the audience. Sure, sir.
In pharmacotherapy, you said one of the drugs are those which are mood elevator. We have modafinil, which we use in somnolence, and the people who have got Parkinson's disorders or senile dementia. Do you think these drugs would be effective in these patients?
These drugs are being used particularly for patients of obstructive sleep apnea who are on treatment and still have residual sleepiness, and which is not resolved with CPAP alone. So for that, I would like to mention that sleepiness is also a multifactorial symptom, where sleep apnea may be one factor. So if you have a patient who has residual sleepiness, we should consider, along with OSA, other conditions like narcolepsy, sleep insufficiency like sleep deprivation, use of sedative drugs, or even depression may be factor, So you have to look for that and you have to resolve that. And after doing everything, if still patient continues to be sleepy, then drugs like modafinil are being used. But recently now in the newer development, you have the Suri amphitol. This is the drug which is specifically being studied to treat residual sleepiness in patients with obstructive sleep apnea.
Thank you, Professor Suri, for such an insightful lecture on the recent advances in obstructive sleep apnea. So I want to know, whatever the recent advances you talked about, so which are the recent advancement which is being practiced in India? And in your clinical practice, which you are practicing? Which are the things you are practicing? Many of the things are which are not practiced in India. So what things you are practicing in India?
The things which are being now practiced in India are the treatment of different endotypes, which are like loop gain, low arousal threshold, and I think these 2 we are doing because if a patient of obstructive sleep apnea, all of them will have obstruction, so you need a device to treat them. But in addition, if they have a high loop gain, so we are giving either oxygen or the acetazolamide carbonic anhydrase inhibitor
How
drugs.
frequently you are giving the patient for the surgery which you mentioned, different maxillofacials, the other surgeries?
They are being done, you know. I think there are many centers in India now who are doing both uvulopalatopharyngoplasty and the tongue-based surgeries, you know. So they are being now, this thing, and drug-induced endoscopy
And
is
sir,
now
the
becoming...
nerve stimulation part? Nerve stimulation?
No, it's not yet come in India.
Thank you, sir.
But it is very popular outside.
Sati, one last question from my side. So I think I'm loud enough. So do you think we have reached with all the choices, the new drugs that we have, do you think we have reached the stage when in 10 years' time, when you do this lecture, we will probably not talk about CPAP being the first line therapy for sleep apnea? Do you think we have reached that stage, or do you think we are still far away from the stage where other treatments will just be add-on to CPAP rather than being a replacement for CPAP?
See, if you say today, it is still the gold standard treatment, because even if you have multiple factors contributing to sleep apnea, the anatomic factors are all present in 100% of the patient. So you will need a device to keep the upper airway open. Along with that, you know, you will add treatments, multiple treatments to, optimize the treatment. So if there is a high loop gain, you treat that, because patient has complex sleep apnea and they are not tolerant to CPAP. So, or we will develop new devices, which we already like. ASV is a device where you use to decrease minute ventilation. So this is one device which actually brings down the ventilation rather than enhance that. So that's it.
Thank you.
Okay. So now we move on to the next lecture.